and get started.
Perfect. Thank you very much. Good afternoon, everyone. I'm Sam Gaynor. Welcome to Understanding Positive Behaviour Support, Restrictive Practices, and the relationship between them. Obviously, there's a few key terms in that title, so there will be a little bit of overlap as I speak through this webinar. So there might be some doubling up on some concepts. So just bear with me as we go through that. Now, I've been coerced into giving a spiel about myself, which I don't love doing, but here we go. I am Sam Gaynor, the clinical manager at Plus Clinical. My journey in the world of disability is fast approaching 20 years. I started as a support worker, did the whole team leadering thing, and went up operations, and then was identified as a person to be trained as a behaviour support practitioner quite a few years ago now, when it wasn't really I suppose a bit of buzz around PBS. And then that started my journey in behaviour support practitioning. Both I've had private practice, I've worked for large national corporations, and about 7 months ago, I came across the fighting chance to head up their Plus Clinical teams. I suppose just on a personal note on why I do this, or the way that I approach the work, is that my mum used to be an RN back in the institution days, and this was before community integration. And I remember very clearly being dropped off at Marsden Hospital in Parramatta, which I believe the building is still there opposite the football stadium, at the end of her shifts while I waited for her to go home. Or alternatively, when she was going out in the community with participants, she would bring them across to my granddad's house where I'd be babysat. And I remember from a young age, I suppose I knew it was predominantly men, were different, but I just didn't care. And I wasn't scared or anything like that. And I think that's inevitably what led me to becoming a support worker. And being a male support worker, 20 odd years ago, I was quickly thrown in with the clients that exhibited challenging behaviours or behaviours of concern. And that's where I suppose my love for where I am now, I suppose, started. So that's enough about me. And it is Sam, but in emails and business cards and all those wonderful things, it's Samuel.
Great, thanks, Sam. I'm Stacey Slavin. I am the head of Plus, or officially the strategic development manager at Plus. I work alongside Sam on a day-to-day basis. I look after both our clinical arm and the day program arm of Plus, which is actually Fighting Chance's newest enterprise. So we launched toward the last quarter of last year, and we are specifically programs for people, as you might have assumed, with challenging behaviours or behaviours of concern, particularly interested in life skill development and improving quality of life. I've been with Fighting Chance for, I believe, 7 years. I've done a number of roles in the organisation. So as I said earlier, it's nice to see so many familiar faces and names popping up in the participant list, and you know who to reach out to if you've got questions after this. So with that, I'll hand back over to you, Sam.
Thanks, Stacey. Before we start, it's obviously important that I do acknowledge of country. So I would like to begin today by acknowledging the traditional custodians of the land on which we meet. I'd like to pay my respects to elders past, present and emerging, and extend that respect to any Aboriginal and Torres Strait Islanders people here joining us today. I'm on Garigal land at the moment out of French's Forest. And I always like to, at the beginning of these things, if you feel comfortable, writing in the chat what lands you're sitting on. And if you don't know, it's always a little bit of a fun exercise to find out, because for the name and the peoples at which you're sitting on, but also you can kind of find a little fun fact usually when you're doing a search, whether it be a certain river or type of tree and an aspect of the area you're living in, which holds value and importance to Aboriginal and Torres Strait Islander people. So, what are we doing here today? Why are we all here? Well, hopefully by the end of it, you will have a better understanding of the key concepts that are on the screen in front of you. like I said, there's a fair bit we're going to go through. So this is being recorded, so you can rewatch it, access some of the links that will be throughout the presentation. But also, if you want to go into more detail under some of the concepts that we touch on today. So we'll be talking about what is a restrictive practice under, and how is it viewed under the NDIS. What does it mean if an RP is recommended as part of a behaviour support plan for a person that you support or a loved one? What is PBS, Positive Behaviour Support, and what role do behaviour support practitioners play in this PBS world? Hopefully start talking about how does PBS play a part in reducing or eliminating the need for restrictive practices. I do want to briefly touch on the difference between PBS and ABA, which is Applied Behaviour Analysis. And that's kind of off the back of a very, I suppose, widespread documentary in Four Corners that kind of showed ABA in a certain way. And I'd just like to explain the difference. And that's not to, especially if you've got any ABA practitioners or clinicians online, it's not to, talk badly about ABA, but just kind of give you all an understanding of the difference there, because there is a difference, albeit it can be confusing sometimes. And then hopefully give you enough information as to if you want to do further research after this on about restrictive practices and behaviour support. There'll be some links and a few documents that we will copy into the chat throughout this webinar that you can open up. I will stop a couple of times before I continue to the next sections so we go through as well, just to ask for any questions so I don't have to answer all of them at the end. So, restrictive practice means any practice or intervention that has the effect of restricting the rights or freedom or movement of a person with a disability. So there is a link there to the National Disability Insurance Scheme for Restrictive Practice and Behaviour Support Rules. That's a very legislative heavy document. I don't expect you all to read that, but it does go through kind of the key aspects of what practices are deemed restrictive and what sort of regulation they're placed under. So when a restrictive practice is, I suppose, prescribed, the decision to use a restrictive practice needs careful clinical and ethical consideration, and it should take into account a person's human rights and the right to self-determination. Restrictive practices should be used within a positive behaviour support framework and should include proactive, person-centred and evidence-informed interventions, which also includes trauma-informed practices. So under the NDIS, restrictive practices need to be monitored, and that is so that restrictive practices can be tracked whether they're being reduced or eliminated over time, which we'll talk about a bit later in this webinar. That bottom link, the Regulated Restrictive Practice Guide 2020, again, rather large document. It is about 60 pages. However, if you do have a look at it, there are some really clear definitions on some of the key concepts we're going to talk about today. It's broken up quite neatly into the sections of RPs, which I'll talk to in the next slide. And also has case studies as well, like real life case studies that are easy to read. And there's also a decision-making tree in there as to why maybe a restrictive practice has been prescribed to a person you're supporting or a loved one. So which would have been done by a behaviour support practitioner. So you can kind of understand where that practitioner is coming from. So in front of you right now are the 5 main categories of restrictive practices that you would hear commonly. You have physical, chemical, environmental, mechanical, and seclusion. In no particular order there, there's just the very brief definition. So a physical restraint is the use of action of physical force to prevent, restrict, or subdue a person's body or part of their body to influence behaviour. Chemical is the use of medication to influence behaviour. Environmental is restricting a person's free access to all parts of their environment, including items or activities. Mechanical is the use of a device to prevent, restrict, or subdue a person to influence their behaviour. And seclusion is a sole confinement in a room space where voluntary exit is prohibited. So in all 5 of those, and again, I've got to talk quite generally today, when those restrictions have a therapeutic base, so usually a medical base, it's not deemed a restrictive practice. So very simply, I'm going to use, say, chemical restraint. if someone is prescribed an antipsychotic medication for a mental health condition, and that is the usual reason that medication will be prescribed to someone, that would not be restrictive practice. However, a common one that we do see is anti-epileptic medication being used as a mood stabilizer. So the primary use of the anti-epileptic medication is to treat epilepsy. The participant doesn't have epilepsy. It's being used to, I suppose, stabilize their mood. That would be deemed a restrictive practice. Obviously, there's an infinite amount of examples to give and whatnot. But if you have any concerns about that, again, these are sort of things I'm happy to unpack after the webinar. You'll get access to our emails and phone numbers and whatnot if you have kind of concerns around that. It's important to note that there is a difference between restrictive and prohibited practices. So prohibited practices should never be prescribed and are usually a violation of the Human Rights Convention, and in most cases are punishable under Australian law. So two common examples of that would be a practice that is aversive or punishment based, that would cause someone an adverse effect or pain, so to speak. And another common one, especially back from, unfortunately, the institution days, is overcorrection. So I spill a cup of milk in the dining room, you make me mop the whole house. Okay. Again, giving general examples, but those sort of practices, if you ever see them pop up in support documents for your loved ones, feel free to get in contact with some of the people that will be in later in the slides to see if this is okay or not, and what you should do about that. Alrighty. Before I move on from that, is there any questions in the chat? Anyone have any? Yep. So what we're going to go into from here is now start talking about a bit more about positive behaviour support and behaviour support practitioners and what they all have to, why they all interconnect. So what is positive behaviour support and what role does behaviour support practitioners play? So a very brief definition, to put it a whole profession into one sentence, is that positive behaviour support is a person-centered approach to behaviour that is focused on improving quality of life and reducing behaviours of concern. Now, a behaviour support practitioner assesses the influences on a person's behaviour and designs interventions to both increase a person's quality of life and reduce challenging behaviours. So the simple equation that I like to tell practitioners that I'm working with is that the happier someone is, the less likely they are to engage in behaviours of concern. And that is for all people, not just with people with disabilities. So again, putting our profession simplistically, but that's what a lot of the interventions and goals around behaviour support practitioners aim to do. And that's also what you're seeing from support workers all the way through to other service providers within the disability sector, is that we're aiming to increase a participant's quality of life. So we're all working towards the same goal. So one key product from PBS and PBS practitioners is the creation of a positive behaviour support plan. So a BSP, they're quite often referred to as. And it is the job of the practitioner to work collaboratively with a wide range of support, service providers and other supports of that person to write this document. And this document's goal is to not only address the person's behaviours of concern and how to manage them in the moment, so a reactive strategy, but also how to, the proactive strategies, how to increase this person's life skills and quality of life and whatnot. Just on behaviour support practitioners, just because it's important to know, I was speaking to Jeff Chan, who is the head of quality and safeguards, albeit he's on leave at the moment, about 12 months ago, and they had completed a piece of research and they found no definitive link between the quality of behaviour support practitioner based on their tertiary background. So one thing that's very unique about behaviour support practitioners is that we have a wide range of backgrounds. It could be social work, psychology, education, OT, right through to absolutely no tertiary qualifications whatsoever. And the NDIS deemed that there was no direct link that a tertiary qualification led to a better outcome of a behaviour support practitioner. It's actually about how that behaviour support practitioner completes their work. And I suppose that's based on their supervision and the tools they have where they're working. So that's just important, because I know one of the, and I did the same thing. If I had a loved one that I need behaviour support for, like, what's this person do? Why are they doing it? Where they come from? What's their qualifications? However, again, positive behaviour support sits quite uniquely in that space. So what does it mean when a restrictive practice is recommended as part of your behaviour support plan? So as we spoke about, PBS support focuses on evidence-based strategies and person-centered supports that address the needs of a person with a disability and the underlying cause of behaviours of concern, while safeguarding the dignity and quality of life of people with disability who require specialist behaviour support. So if we take that bit of that blurb there, and we look at the safeguarding the dignity and quality of life. And this is where restrictive practices can be prescribed or introduced to an individual. So the use of a restrictive practice, albeit it restricts someone, say their movements or their access to something, it's so that they can trial something or upskill, or it increases their quality of life in a certain way. So as I spoke about before, if someone was on a anti-epileptic medication to stabilize their mood, while their mood is stabilized on that chemical restraint, we would want to be teaching them life skills, so that about maybe self-regulation, emotional regulation, better means of communication, because when someone's in distress or a heightened state, they can't learn, and therefore, or they have limited learning capacity. So therefore, the likelihood of that skill being learned is heavily suppressed. So you would introduce a chemical restraint for a period of time to hopefully teach this skill. And once the skill is taught, they should be able to self-regulate without the medication. Okay. One of the other ones is, a very common one is certain harnesses in vehicles, or screens and locked doors. So basically safety protection gear while transporting in, say, a van. If that person didn't have that to, say, protect themselves, other people in the van, or the driver, they would not be able to be transported safely, and therefore they might be stopped from being transported. Therefore, they're essentially homebound. But the introduction of this mechanical restraint allows them to access, say, their day program, their community, or whatever that looks like. Again, it would be the job of a behaviour support plan to start looking at the cause roots of the behaviour, so that eventually we can get rid of the mechanical restraint, because whatever need they have while being transported has been addressed, and they no longer need to be mechanically restrained in a van. Hopefully that makes sense. It gets a bit technical sometimes, but hopefully with all these key, I suppose, ideas you're going to get through this webinar, it starts building a bigger picture of what positive behaviour support framework kind of talks about. Now, you're probably thinking about, well, this sounds like this positive behaviour support practitioner has too much power. They can just prescribe these RPs as they want. They can do whatever they want. They can't, which is great, and I'm glad they can't. In New South Wales, for those that are joining us from New South Wales, we have DCJ, formerly known as FACS, run an independent panel for providers. So all restrictive practices have to go to a third party, which is an independent specialist that sits under DCJ. And they have to discuss that with, say, the practitioner, a service provider, and the third party specialist. And they essentially accept or deny, or they say this requires amendment or changes based on their beliefs and what their point of view is of that practice, whether the practitioners have done their due diligence, and also whether the implementing provider will be able to actually implement that practice. So that's kind of a safeguard mechanism that's in place, which hopefully reduces any kind of over prescription of restrictive practices. So for the parents on the line, what that might look like for you, that not all RPs will go through a DCJ panel necessarily, especially if you have a child that's not accessing other NDIS services. However, there are certain kind of other professions and information lines and places of information that you can talk to, and they would at the end of this slide, so that if you don't feel like you have these safety nets, or you feel like you're possibly not requiring an RP, or you just want more information about why an RP was prescribed to your child, then you can go look at those or talk to the contacts at the end of this. Okay. So as I just said, if you want to have a chat, the key people to talk about your behaviour support or restrictive practices are your support coordinators. So if you have a coordinator of supports, that is a really good starting point, because they're essentially the conduit for all your services. They don't have the knowledge themselves. They should definitely have the contacts of who you should talk to. Feel free to question the behaviour support practitioner. There's nothing wrong with asking why, or tell me more. Or can you please provide evidence as to why you're doing it that way? Other service providers or service provider managers for the services that you're accessing, and being like, well, why does that need to be used in your service? I don't use that at home, or should I be using that at home, or whatever that looks like. Having a good chat about what it looks like across different environments for the person you're supporting. And then for advice and also technical advice, you have the NDIS quality and safeguards. Now, they're the people that essentially all practitioners like myself are registered under, and they're also where the vast majority of behaviour support plans get uploaded to, and they monitor the quality of the plans, but also the restrictive practice usage. So yeah, that's who I would start with. And again, there'll be links and numbers and emails at the end of this webinar as well for further information. Any questions on that?
Just checking to see if there's any questions in the chat. I think we...
Hi, Sam. Alessandra here from Fighting Chance. We have one question come through the chat. It's a question from Rando, who I believe is in Melbourne. Is it possible that positive behaviour support is suitable for somebody with neurodivergent and complex mental health or trauma disability?
Yes, thanks for the question. Yes. However, it would most likely be in conjunction with a medical team as well. So positive behaviour support is quite often one piece of the puzzle, and one kind of way I also like to look at it is that it's also another, I suppose, conduit piece. So we would collect information from as many sources as possible and place them into this behaviour support plan. So what's happening for this person, what's working, what's not working, what other services can we connect them with, what services are missing. So essentially like a mind map. And that's one way that we start working with all participants. And I ask my practitioners to do that, is to put the participant in the middle and then draw lines out and be like, imagine this was you. What have you got? What don't you have? And what not? So does this person have a social group? Do they have, what do they have? What don't they have? And in the example that you just spoke about, obviously one of the things that they'd be talking about is, well, there's a mental health condition. So therefore, are they being supported for that? There's a neuro condition. So are they being supported for that? Because the behaviour support practitioner, they might specialize in helping individuals like that, possibly not as well. But what they'll want to do is ensure that there is someone giving those informed information to. Someone's just started sharing their screen. So we're sharing on sharing. Might just wait for a second to see who that was.
Sarah, I think that's you. There's a Sarah on. No doubt an accidental tap of the mouse pad, but
just while we're sorting that one out, and we've got another question coming through the chat from Vivana, who's asking, what do you suggest behaviour support practitioners do when an unauthorized restrictive practice had been identified and the service is not acknowledging?
Yeah, so this is when it can get quite tricky, because URPs are quite dangerous. What you can do is you want to have those, like anything, have those conversations in the first place. It sounds like there's a bit of a breakdown with opinions or communication there, in which case you would be calling quality and safeguards for further advice, because they take URPs very, very serious. And that is something that, sometimes they can URPs in a sense can be used without fully knowing that you're using them, or they haven't been identified properly, in which case they should be quickly either documented or removed. Or there's the nastier side of that, where they're being used intentionally, in which case that would be essentially straight to a reportable. So if I knew about that, that would be a reportable incident because I'm a practitioner under NDIS. But for other people, they would call Quality and Safeguards and say, "Hi, I think this is happening," or "This is happening. Please advise what I should be doing." There is a Quality Safeguards email for every state and territory, but there's also a hotline you can call as well. And usually when I call it, the wait times are minimal, which is great for a government department. Now, can everyone see my screen? Are we back on track?
Back on track.
Awesome. Thank you very much. Hopefully I answered those two questions okay for those that asked. So thank you for putting those in the chat. So now I kind of want to have a chat about what to expect from a practitioner. Like, you know, what should I be expecting the service by the end of the service and whatnot, and I suppose the conduct or the actions of the practitioner. So positive behavior support works from the following ideas, and that is that all behavior serves a purpose. You know, there's a reason we're engaging in those behaviors. Which, if you know, I'm trying not to throw too much jargon at you, but that's where we create our functional analysis or functional assessment. So before we engage in any work, we should be doing a functional assessment, because we're making, you know, we're doing a hypothesis, a scientific guess. We're trying to guess why they're doing that, because if we guess correctly, then the strategies that we're going to provide are more likely to be effective. So more often than not, behavior is often an attempt at communication, or I suppose a communication of frustration that there's been a communication breakdown. And that happens a lot. And it gets to the point where a participant feels the need that they're not being listened to or heard correctly. So they essentially escalate and escalate and escalate to a point of exhibiting behaviors of concern. We should always assume positive intent behind behavior. So that's the concept that you know, they're not doing it to be a bad person or evil or because they dislike you. They're doing it because there's been some breakdown in their need, and this is a tool that they've either learned or have gradually had to build to get their message across. And there's a lot of examples when you know, if you're speaking to a behavior support practitioner, you're like, oh, this is actually what they're trying to say. Like, oh, they were trying to say that earlier, but I missed the cues. And we miss cues all the time. And that's because people are busy. We might not have the knowledge to pick up those cues, all those sort of things. So yeah, it's just important to know. And kind of goes back to that question before with the neurodisorder and the mental health, that behavior is a complex mix of biological, social, and learning factors. So there are a lot of different reasons that someone can exhibit a behavior concern. And obviously, the more of those that you add, the more complex it is to kind of unlearn or learn new skills to combat those behaviors of concern. I think it's important to note, I've just realized I haven't put the original definition of what a behavior of concern is, which is quite important. And that is a behavior that is of such frequency and intensity that it places a person, a member of community at risk, or it risks their access to community or an activity. So if someone is engaging in a behavior that is harmful to themselves or others, that can be seen as behavior concern, or if it's stopping them from engaging in their normal, I suppose, everyday activities at the community. So it's important to understand that, because there is kind of like normalized behavior, which is like age appropriate and whatnot. And then there's behaviors of concern. So unpacking those with your behavior support practitioner is also really important, so that we don't start thinking that everything is a behavior. You know, we all exhibit behaviors every day. You know, if you're driving in Sydney traffic, you're probably exhibiting a few every morning and afternoon. That doesn't mean necessarily that you have a behavior of concern. I think it's also important to note here that behavior support is not talk therapy. While it is therapeutic in the sense that we might be providing kind of advice that might feel like it could be relationship advice between you and a loved one or a support person, or it could be therapeutic advice based on interventions. It's not like your typical, you'd see your couch therapy, your psychologist. That would fall under improved daily living funding, and you would engage in an appropriate therapist for that, whether they're a social worker, psychotherapist, psychologist, okay? A behaviour support practitioner deploys positive behaviour support, and that usually is in the form of a behaviour support plan. Second, let's see if I can. Yep, cool. So when working with a behaviour support practitioner, you might get asked a wide range of questions. If you feel uncomfortable answering those questions, that's totally okay. What you want to do is work with your practitioner in ways in which information can be collected that is safe and in a trauma-informed manner. And that's because when we're writing our plans, we need to know a lot about the person, because it is essentially, for lack of a better word, a holistic approach to the person. So we want to know about their developmental history, their learning background, their social supports, diagnosis, and other personal factors, which can include, and quite often does include, say, childhood trauma, and other factors, family deaths and things like that, which can be upsetting to talk about when you're the person being interviewed. Because also often is the case, as much as we should and we do incorporate the participant in this process, getting, I suppose, a lot of our answers requires us interacting with other people that support that person. It's really important to note also here that a positive behaviour support practitioner should always appreciate that the people they're talking to know the participant best, not that the practitioner knows the person best, okay? So if you feel like you're getting that from the practitioner, it might be time to question that. It's more of an exploratory relationship rather than being told it is what it is because I said so. So you've got a practitioner. They're going to produce a behaviour support plan, like I said, in 99% of the cases. What should a plan look like? So the plans essentially go through in multiple sections. Some of the documents are quite lengthy. Unfortunately, that's because of our practice standards under the NDIS. It's very hard to trim it out without meeting those practice standards. But also, a positive behaviour support plan is derived from person-centered approach, which is humanizing the person. We want to be able to know this person by reading this document. So we also love to talk about all the great things about a person, because a person is not a behavior. A behavior is just something that they do. So we'll talk about the person, the environments that they interact with. Obviously, we've got to talk about their behaviors of concern, and there's our functional behavior assessment or analysis. We then formulate, okay, what's this all mean? How is it now, turning into a behavior concern, and what are we going to do about that? And the intervention will both be reactive, what to do when it's happening, but more importantly, proactive. So how are we going to reduce this happening over a longer period of time? And that includes all your learning strategies, which includes teaching or implementing properly, which I believe I go into in one of the latest slides, but that's making sure that we're building up the supports of the support persons. We're building their confidence, their skills. Because again, we're a practitioner that drops in and out. Even though we're kind of along the journey with you, we're not there all the time. We're not the ones providing that on the floor care or support. So we really need to ensure that people are doing that are feeling confident to do those supports or to help learn those skills with that participant. So you will more often than not have a comprehensive behaviour support plan, which is what the technical term for what it's called. There's generally two types of plans under the NDIS, an interim and a comprehensive. I'll very quickly explain the difference, but I don't want to get too deep into it. An interim we need to do is more like a safety plan because we have up to 6 months to write a comprehensive, but we only have 4 weeks or 1 month to write an interim. And that's meant to keep the participants safe while the comprehensive is being written. So the interim will definitely be a little light on information, but should provide enough information to care or support that person for the immediate future. And then once you get your comprehensive, that'll be valid for 12 months. and there'll never be another interim written if you stay with the same service provider. So there's no need to write an interim and a comprehensive every year. It's just that the first time you engage in a service, then the comprehensive is written, and 12 months later, it will be reviewed. Best practice means they review it a couple of times during the year, obviously to check in, to make sure things are going well. Does anything need to be added or removed? But the actual, I suppose, valid dates of the comprehensive is a 12-month period. In a comprehensive plan, they will obviously be defining the challenge behaviour or behaviour concern that is observable and measurable. They'll help identify specific predictors of each behaviour, so the setting events, analyse what's triggering the behaviour, and identify environmental changes that are needed or that you can, I suppose, manipulate as a support person or the practitioner. Now, there's a link there to Evidence Matters, which Dr. Erin Leaf, and I can't remember her colleague, wrote, which was, it breaks down all the subheadings that you'll see in a behaviour support plan and why each of those headings are important and what to expect from that. So if you're getting a behaviour support plan, you think this is 50 pages of junk, feel free to open up Evidence Matters and see if it does answer the questions that are written in that. I think it's about a 30-page document. It might be slightly less, but it's written quite well. They've removed a lot of the jargon, and it's really a matter of fact. And I think it's a great piece of work to keep practitioners in line to ensure that they're producing a quality behaviour support plan. So there's also, on that, you'll notice if you do read it, that the NDIS did just conduct a review of all behaviour support plans written in New South Wales. And I think it's about 3,500 plans a year are written, and overwhelmingly they are of poor quality. So there are a lot of bad or poor practitioners out there. And I think it's important that people understand that and understand that it's their choice and control to change practitioners, or at least ask the question, why isn't the work quality better, or what could be changed? Okay. Now, I've just realized the time. Usually I speak too fast and I run out of time. So I'm going to try and pick up the pace a little bit, but we're almost at the end. So bear with me. So how does, I suppose, positive behaviour support get rid of RPs? And as I spoke about, the behaviour support plan is the centerpiece of that. It kind of gives this whole picture of a person. And then once we do that, we can start seeing where the gaps are or what we should be targeting. And that should give us direction how best to support this person, which will hopefully in turn increase their quality of life. Okay. Now it needs to be implemented properly. The practitioner needs to train all parties involved. And again, in that Evidence Matters document, it tells you what good implementation looks like. It's not just a 30-minute, let's join Zoom and I'll read off the plan. That's not great implementation. It involves collecting data, which is generally done by the people that are supporting. However, it's the practitioner's job to collect it and analyze it. For those that are asked to collect data, I generally ask my practitioners to do it in like 10-week blocks, because I can't ask someone to collect it for 52 weeks a year. That's unreasonable. But if you are asked to collect data, it's really important that you try your best to do that. If you're struggling to collect it, ask the practitioner for other ways, because you can do it through your phone. We can do it by simple scoring. There's other methods to do it. That data really reinforces if something is working or not working. And I feel like one of my most powerful examples is when I was a support worker. If someone was physically aggressive to me, say punches me 10 times a shift, and that drops down to 3, I'm still feeling like nothing's working. This person's still punching me. But then if someone said, hey, it's dropped by 70%, you're like, okay, what we're doing must be working. Let's continue on that. And sometimes you need that data as motivation that you're on the right track, because a lot of PBS strategies are long-term. A review. So practitioners should be keeping tabs with you over the journey. Usually we're looking at bare minimum 3-month review or 6-month review of the plan. However, the actual bare minimum is every 12 months we review that plan. However, it wouldn't, that's not best practice. And then referrals, that's referring on. The behaviour support practitioner is not the be all and end all. They should be identifying where other people are required to come in. And that can include a plan review letter that we write at the end that this is what we've done over the 12 months, this is what we achieved, and this is what we think in the next 12 months from a behaviour support practitioner's point of view. And usually in our case, it'd be like, we need a speech pathologist to help with communication. We need an OT to help with sensory observations and so forth. Alrighty, I said I'd have a quick crack at the difference between PBS and ABA. Now, this, I will straight up say, this table in front of me, I did not create. This is from Aspect, who is a leading provider for participants with autism. They have great resources on their website. This is freely available on there. And they apply PBS across there. They have Aspect schools, but also they have Aspect services, group homes and whatnot. So one quick way I like to explain it is that ABA and PBS kind of started on the same, if it was a capital Y, and they get to a certain point and then go their separate ways. There's also a link that'll be put in the chat to Autism 360, and that's just a one-pager on the difference. And I think that the two main points from that I'll just jump into is that PBS emerged in the 1980s as a response to concerns over ABA practices at the time. And it was to, it wanted to have a person-centered trauma-informed model applied to the way that it conducted its practice. So ABA tends to focus on a specific behaviour or reducing that behaviour. So a very particular, I suppose, thing that someone is exhibiting. Whereas in PBS is working on the environmental kind of long-term focus, which is sometimes called nonlinear or constructional approach. So that's where, think of that mind map I spoke about, where we're looking at what are the boxes that are missing, what boxes can we add, what are the boxes that are there that we can lean on to help us get through this. And as it says there in the PBS, what it isn't, again, it's not a therapy. It's very different to that early intensive behavioural intervention, which is what a lot of children under the age of 9 might be engaged in. And we're essentially not trying, although our focus is to reduce behaviours, we're not targeting the behaviour of concern as such. We're trying to target the cause root of the behaviour. Whereas in simplistically putting it, and sorry if I offend any ABA therapists online, they may be targeting a specific skill or behaviour specifically. Okay, but you can read that table later. The links will definitely help explain that in a bit more depth. And I want to thank Aspect for that table. Now, as you can see, there's some more information. You've got the National Behaviour Support team at the Commission. That's the New South Wales variant. If you're in another state, it is just instead of that NSW, it would be, say, Victoria, SA, NT. You just change the state. All the emails are the same. You've got your national line there. That fax email is the DCJ email. So if you want more information about how a RP was accepted, or you want more information around that, they might be able to answer those, or at least refer you on to somewhere that they can. Got the People with Disability Australia and Disability Advocacy numbers there, contact details, and they're great if you don't want to speak to another government body or the service provider, and you just want a neutral person to contact. Call them, and they should be able to help you with whatever kind of is the need there. As also said, speak with your LAC, coordinator of supports, or your behaviour support practitioner. Hopefully you've got a good relationship with them if you have any concerns around this. Also keeping in mind that education, health and aged care also all use positive behaviour support. It's generally considered the best approach currently in those respected fields. However, they have their own kind of bodies that overlook those. But if you definitely are interested, feel free to have a look at that, or talk to the school. If you have a person you're supporting in a school, ask them what they're doing. Question time. Sorry, I chewed a bit into it. We've got 10 minutes left if there are questions. Again, if you're not feeling up to asking it over this forum, and again, I don't want to answer any like personal questions in a public forum. You will have out on the next slide, have our contact details if you want to reach out after the fact. And I'm happy to have a chat about this. And yeah, or if you're seeking behaviour support services, our team does have capacity at the moment to take on some new referrals, or if you know of someone that is looking for a new behaviour support practitioner.
Yeah, so just unmute yourself if you've got a question now. Don't be shy, because often someone else on the chat has the same, or someone else in the call has the same question. Really happy to field any of these questions on that email address that you see on the screen afterward. Someone just asked, where do you service?
Yeah, so we're currently servicing all of Greater Sydney. So if I kind of look at it, you're looking at the Campbelltown, around to the Penrith, around to the Hills District, and then the Northern Beaches. So quite a large radius. However, PBS can be delivered through telehealth if it's, say, an area where you can't get any services, or the services in your area aren't very good. We definitely can do telehealth or clinic-based, where we might absorb the cost of sending someone out to an area, say for a night, put them up in a hotel, do some intensive work, then come back and do all the written work from our hubs. So there's definitely workarounds. You know, I helped a large national organisation through the COVID period and continue their services through that. So I'm well versed in how it can work in different ways if it can't be face to face.
Hey, thanks, Sam. Well, it doesn't. You must have explained it so well that no one's got any.
Hopefully I don't have deers in headlights with too much jargon. So I'd like to thank everyone for joining today. If you feel like the information was helpful, feel free to share the webinar once it's sent out to you all, because I'm quite passionate in making sure the sector does good behaviour support. And currently it's not doing its best. So therefore it's not doing its best by the participants, and that upsets me somewhat. So yeah, hopefully this gives you a bit of information, a bit of empowerment to go question that, or to seek better services.
Sorry, we do have one question just at the end. Someone asked, what do you think of organisations like Behaviour Support Practitioners Australia for advice services?
Yeah, so BSPA is headed by one of Australia's best behaviour support practitioner, I suppose, academics. However, it's also then on the board of directors it actually has a person that taught me how to become a behaviour support practitioner, Dr. Jeff Potter. And I know for a fact, having worked very close with him at the beginning of my career, that he wants nothing more than to advocate for participants first and foremost, and good behaviour support practicing in Australia and the world. He has a lot to do with the UK and the US as well, because he was trained by IABA, which is essentially where PBS was founded over in California. So I think that's an organization that's trying to grow at the moment. So they're trying to formalize registration of behaviour support practitioners outside of the NDIS, so that we can build higher quality practitioners in Australia. So I think they're a great place to start. I'm a member of BSPA. I attend their webinars and whatnot, which are great. And I know that they're trying to build what they can do for the disability community in Australia. And hopefully they become, I suppose, almost like legislated, so that, yeah, they have a bit more power.
And it looks like one last question, which is, how long or how many hours should it take to write a comprehensive plan?
Yeah, I suppose how long is a piece of string for that one, depending on individuals. However, it does take quite a while. Generally speaking, you'd be pushing it with, I suppose, a package of about 30 hours. Most companies will have a benchmarking, so a bare minimum. And usually, although that can definitely be seen as kind of a money grabbing exercise, it's more so in the way I like to approach it, to ensure that we can produce a quality product at the end. If you do have any funding issues or shortages, that's definitely something you should talk to with your support coordinator, or the behaviour support practitioner, and see if you can come to some sort of arrangement. And that's why I suppose I can only speak from our experience. At the beginning of any service, I would ask our practitioners to write a support plan, which breaks down kind of where the hours are going to go and what's going to be produced at the end of that. And obviously, the more hours there are, the more they can do and add to those services, or the less hours, the less they can do. But we want to be upfront with that, because it does take quite a while to write and to gather information to write a good plan.
Great. Okay. Sorry, there's just a few messages saying thank you. I'm just reading through the.
There's one other question that came in around where a client has both specialist positive behaviour support and BMP funding. Sorry, this is my lack of understanding sharing, but I'm not sure BMP funding. I'm sure Sam will know what that is. Do you have the same clinician working on both or different clinicians?
Yes, I think what you're talking about, the two line items under improved relationship. Technically, the one is for, say, the writing, collecting of information, and the other is for the implementation. You can have practitioners do both. Quite often that funding gets lumped together for the practitioner and they'll just do it all, because the line items aren't necessarily evenly distributed when you get your NDIS plan. So sometimes it would be 10 hours to write the plan, but 50 hours to implement it. And you're like, no, wait a second, I'm going to have to use some of those implementation hours to write the plan. So again, that should be explained in the support plan, that or the pre-planning, depending on what service you're with, so you know where that funding's going. There was also one quick thing I didn't talk to in the slides. I just wanted to mention that I wasn't talking about the Royal Commission findings and whatnot, purely because that's a big piece of information. There's also quite a lot of other webinars and information out there, and it's currently the information is somewhat incomplete as well. So that might be something that we touch later on in the next couple of months, for those that are concerned about the findings of the Royal Commission and what that means for restrictive practices, behaviour support, group homes, and the disability education sector, because I know there were some pretty big things that came out of that.
Right, I think that's just about it, unless anyone chimes in at the last minute. But again, our details are on the screen there if you have any questions or indeed seeking more information about a practitioner for you or your person. Otherwise, we will end our webinar there. Thank you all so much for attending today. It was great to see so many people joining up.
Thanks, everyone. Have a lovely day.